for some reason or other, early on in my training, which was with Duke Sampson and Hunt Beecher, I was always fascinated by arteriovenous malformations, and I have to admit that I still believe and think that it is one of the few things that neurosurgeons can hold on to, hopefully for a while longer. It still, in my mind, requires surgical talent, although with endovascular therapy and radiosurgery, we are able to tailor the treatment plans that we offer to patients. And I want to spend some time going through with you my thoughts on when surgery is indicated and what we do in a unified way with multiple disciplines to try to reduce the overall morbidity associated with the resection or treatment of AVMs. And you'll note that I used the word morbidity. I didn't use mortality. And that's because when we recently reviewed our patients, we didn't have any mortality. And I think that these are things that, let's see here, I guess I have to do this there. We can treat these lesions safely. I don't have any conflicts of interest or disclaimers that I need to clarify with you. And I'm redoing the AVM book that I did about 13 years ago on intracranial AVMs. And the new approach that I'm taking is I think that it's important for we as physicians to be able to communicate with our patients. And whenever I meet with a patient on any disease that they've got, I always focus on what do you have? What does it mean to have it? What are your options? And then what are the risks associated with the option that you choose? And then obviously, in the book, we go into more detail about the factors specific for surgeons involved in the care of these lesions. At the end of this, I hope that you learn that the management of arteriovenous malformations is not just simply surgery or radiosurgery or endovascular. It's an integrated process where we interact in a multifactorial team to try to come up with a cure. I want to give you some current thoughts on the molecular biology of AVMs, and this may actually lead to something in terms of treatment with anti-VEGF agents in terms of shrinking the size of an AVM. But I do want to leave you with the feeling that surgery is still the gold standard. However, it should be in carefully selected patients. I'm not an endovascular or radiosurgical nihilist, but I think that it's best for a patient to get the lesion out if you can. And again, you know that there are a broad range of intracranial vascular malformations seen on this. And it's a little bit of a misnomer to say that there are benign proliferating vascular lesions and that an AVM, brain AVMs, fall within the non-proliferating lesions, when we know that over time, when you look at a pediatric AVM or even an adult, there can be recruitment of new vessels. So there is proliferation of new vascularity within the AVM. Hence, if a patient is followed over a long period of time, you have to use multiple imaging modalities to stay on top of what the lesion actually looks like. I'm sure you're aware that these are high flow, low resistance lesions, and the angiomatous changes that occur from pediatric to adult involves recruitment and neovascularization. You can classify them into, as seen here, more of a fistulous 1 or 2 feeding vessels, or a racemose type with a well-defined nidus here. In the pediatric population, the nidus isn't frequently as well identified. And we all know that the number of associated aneurysms is actually very different, depending upon how you count them. There's the distal proximal type, there's the feeding vessel aneurysm, there's intranidal aneurysms, and then the venous varices can also be included in that. And then there's also some pseudoaneurysms. And some reports will say that it's up to as high as 40% association. With the improved imaging technology, we are certainly getting better at defining the nidus of an arteriovenous malformation so that we know and can differentiate between terminal vessels, which end in the nidus, functional vessels, or the term we used to use is vessels en passage. And then over time, there's indirect ingrowth from new vessels, and we always have to look for the deep posterior choroidals, choroid plexus, and middle meningeal type of feeding vessels. And this is just an example of how we have to think about this. This is basically, basically a tumor of blood vessels. And I always show the slide on the right here because this is an AVM earlier on in my career that was treated with endovascular therapy and quote, cured. But at that time I was still operating on them, and I went in and you can still see that there are some rather bright red vessels consistent with arterialization of the AVM and the draining veins. Fortunately, when you're talking about AVMs, there isn't any eloquent cortex in the center of the arteriovenous malformation. And I think that there's a conversation we can have at the end if you want about the utility of awake craniotomy for resection of an AVM when it's close to eloquent cortex. I think that number one has to be prepared. You can't do a subtotal resection. This is not glioma surgery or any other type of tumor surgery. I'm not a strong advocate of awake craniotomies. I personally feel that I can get adequate information from a functional MRI to make what I think is a reasonable clinical decision for the patient. But when we're thinking about the pathology, one knows that there's disruption and duplication of the internal elastic membrane. There's thickening and disruption of the tunica media, breakdown of the actin and myosin fibers. There's disruption of the nuclear components. There's fibrosis. There's patchy calcification. There's blood clot within the vessels. And we'll talk a little bit more about the molecular markers that we see in these patients. As I said, there's nuclear abnormalities and total disarray and absence of the tunica media, which all play a role in the increased likelihood for rupture. Little functional information is known about the molecular mechanisms predisposing patients to the formation of arteriovenous malformations. And most of what we know is from vertebrate studies on angiogenesis, vasculogenesis, and stem cell biology. Until recently, over the last 12 years, when blanking on his name, the anesthesiologist who was at Columbia with us and then moved out to UCSF, and they developed a tetracycline notch knockout mouse model for arteriovenous malformations. And we've been able to study these lesions now a little bit more clearly. That being said, in mice, and you all know that we've cured brain cancer and we've cured stroke in mice, but I'm not sure that we'll be able to cure AVMs in human beings. And what do we know about the molecular biology is that, and this is from human tissue, that the disease susceptibility is resultant from genomic polymorphisms. There's an increased rupture from AVMs, from cytokine release, such as IL-6 and tumor necrosis factor. Other factors play a role in sporadic AVM development. These cytokines are seen again at the gene loci level and may play a role in AVM rupture. KRAS mutations in the formation. Inflammation, which you can imagine, plays a very large part in the hemorrhage risk in terms of breaking down not only the vessel wall, but also the matrix metalloproteinases and the stability that they provide in the extracellular matrix. So all of these factors have been identified to be upregulated and or downregulated in the human condition. As I said, all of these are upregulated, but they don't show that any of them clearly induce the spontaneous formation of intracranial arteriovenous malformations. So now we've just told the patient what they have, okay? The next question they need to be asking you, and I try to ask the patient these questions for the patient before we even start, so that they don't go into their long-winded detail about every aspect, every headache they've ever had in their life, and might that have been a bleed? Because you know as well as I that those are irrelevant components. We have very specific factors that you and I need to focus on as a physician, and we need to get the patient to focus on those as well. So from an epidemiologic standpoint, these are obviously not as common as aneurysms. They're 1 per 100,000, but the prevalence is actually quite high, about 18 per 100,000. And they, the easy answers, they typically present with either a hemorrhage, a seizure, or a focal neurologic deficit. However, that being said, with the increased availability of CT scans, CT angiography, and MR scanning, many more people are presenting with incidentally found arteriovenous malformations. The presentation in the adult population is more commonly it's about 50-50 between seizure and hemorrhage. In the pediatric population, they more commonly present with hemorrhage, and the hemorrhage is usually intraparenchymal, but it can be interventricular as well as subarachnoid. Rose Dew did a very nice review of what it means to have the AVM in terms of the initial hemorrhage. If one looks, you can see, and again, this data goes all the way back to the work done by Crawford. This is back in the 80s when I was starting in the field. Basically, the rate is somewhere between 2 and 4%. But then once they present with their hemorrhage, what's their re-hemorrhage rate in the first year, and then their overall hemorrhage rate? You can see that the range for re-hemorrhage in the first year is anywhere between 6 and 16%, and then it comes back down after that first year to range somewhere between 2 and 8% per year. The Andra study, when he reviewed the Finnish data, also indicated that the average interval between the initial presentation with symptoms, i.e. Seizure or bleed, was 7 years to the next bleed. So managing these is more of a chronic problem than it is an acute problem, unless the hemorrhage is so sizable that you have to treat the patient acutely or provide decompressive procedures. How do we go about working these up? Again, it's done with CT scans, and you can see now with spin technology and CT angiography, you get these beautiful pictures. MR is obviously a standard way, and then the gold standard is digital subtraction and super selective angiography. And for patients like this, where it appears to be located close to the motor cortex, you're going to do a functional MRI scan. And I think that, with the quality of neuroradiology that you have at Swedish and a functional MRI and these imaging studies, you can make a pretty close approximation to whether you're going to be kissing eloquent cortex or not. And you have to ask yourself, what does the region close to that eloquent cortex looks like? If it's very friable, frothy, fuzzy little blood vessels, the likelihood that the AVM is not going to take you into the functional cortex is slim. So I think you have to develop your treatment plan based on that information and the treatment plan. So now what are the options? What can we do about it? Well, one of them is observation. One of them is endovascular surgery, radiosurgery, and microsurgery. And obviously the patient wants to pick the least invasive, so many of them want to observe it. And depending upon their age and other issues, that may be the best thing. I don't push surgery where I don't think that it's warranted. Just wanted to touch a little bit on Aruba and the deficiencies. the problem that we all had with it is that only 13% of the patients that they saw were entered into the trial. I'm sorry. The total number of patients wasn't very large, 109 in the medical management and 114 in the interventional group. And the biggest problem that I have is that the interventional group, out of the 114, only 17 patients were offered surgical intervention. And that's in a population that was predominated by grade 1 and grade 2 Spetzler-Martin AVMs. So you have a disease that has a long natural history, a study that only went 33 months. The one thing they did show is that there's an annualized rupture risk of 2.2%, which is consistent with what everybody else has shown. When they extended the study to 50 months, they lost 50% of their patient population. And again, they suggested that medical management was superior to surgical management. However, of the 22 patients who underwent microsurgical resection, 21 were cured. So a lot of people, including myself, obviously, don't feel strongly that the trial in any way affects the way I have a conversation with patients. And so I go through a number of other factors in regard to recommending treatment modalities. So what patient do I think is ideal for observation? Well, they have a low natural history risk. They finally got an MRI scan when they're 75 years old, and they're asymptomatic, and they don't have any feeding aneurysms, intranidal aneurysms, or venous varices. They've got multiple medical comorbidities, and or it's sitting in eloquent cortex. Obviously, in my mind, the grading of an arteriovenous malformation, I know we all use Spetzler-Martin, but for me, it's more like real estate. It's all about location, location, location. If something is sitting in eloquent cortex and you don't have a pathway to get to it that won't result in neurologic compromise, it's hard for me to recommend to a patient that's asymptomatic and incidentally found AVM that we should go and do something about it. So again, the criteria would be age, severe medical comorbidities, an eloquent cortex, and large size. Obviously, the bigger it gets, the more likely the lesion is to extend into eloquent cortex. That being said, I'm also not one of these gunslingers. I know I trained down in Texas, but I think that I learned appropriate clinical judgment in that I think one makes the decision and recommendation of the patient based on the best information at hand, not on the basis that a chance to cut is a chance to cure. So when I was up at Harvard, I did do a fair amount of stereotactic radiosurgery. During the middle of my experience there, I reported on 128 patients. And one of the problems that you will find in all radiosurgical data is patient dropout. I had 3-year follow-up on 98 of them, and 12 of them were less than 3 years, but it's still 18 patients refused angio or they got lost to follow-up. That being said, I achieved a 76% obliteration rate, and this was using the Varian linear accelerator. When Bill Friedman reported his experience in the University of Florida, again, he showed, he claimed a 79% overall obliteration rate. And you'll see that smaller lesions didn't necessarily have a better response. And most of these that did respond were equivalent to grade 1 and grade 3 in the Spetzler-Martin scale. But most importantly, you see that he only reported on 79 patients, of which 119 patients out of the 314 that he treated totally. So again, it's always hard to know what the real numbers are. Why were those patients lost to follow-up? Gary Steinberg, when he reported on his proton therapy, found 100% obliteration for lesions that are less than have a diameter of less than 2 centimeters. But again, he's only reporting on 89 out of 400 patients treated. So what happened? to those other 311 patients. What are the major issues with the radiosurgical data? It is the incomplete reporting of the results. Most of the results that you see is level 4 evidence. And we've not really clearly defined what the ideal population is for SRS, even though we do have now SRS grading scales. We, I think, now do have an ideal dose that we want to provide to the margin. I believe strongly that the decision to treat a lesion with stereotactic radiosurgery should be made by a balanced team, including a microvascular surgeon, physicists, radiosurgeons, and endovascular surgeons. So this is an example, however. This is back when I was in Boston. There's a 21-year-old woman that presented to me, had headaches, got an MRI scan, and found this AVM. You can see that it's sitting right above her tectum. She was young, attractive, completely asymptomatic. We treated this with stereotactic radiosurgery, and you can see the result on the right side. Surprisingly enough, she looked me up when I had moved down to New York 20 years later, had recurrent headaches and was worried. So we got an MRI and an angiogram, and again confirmed the lesion was still obliterated 20 years out. For larger lesions, that's where surgery is difficult. It's also difficult for stereotactic radiosurgery and for embolization. But here we try to use combined therapy, and with radiosurgery, we're using more fractionated paradigms where we treat the entire AVM. So we fractionate by dose, we don't fractionate by volume. By fractionating by volume would mean that you are picking out segments of the AVM being fed by a specific vascular pedicle and working your way around the arteriovenous malformation in a fractionated way. We've used the volume fractionation, the dose fractionation. And again, the results with this, you get an obliteration rate, depending on who you read, of somewhere between 20 and 40%. And then you get lucky. This was a 30-year-old gentleman that I treated. You can see that he's got an AVM sitting in his basal ganglia and thalamus. He was having functional problems with motor deficits on the left side of his body. We treated him with radiosurgery, and fortunately enough, after 3 years, it went away. He had a very difficult time with the secondary effects. He was on long-term steroids for the swelling and T2 weighted changes that he had on his MRI scan. When I think about treating AVMs, I like to put them into these categories, the Spetzler-Martin scale on the left side, and then the grades. And if you look at this, really grades 1, grade 2, and grade 3 are the ones that are possibly best treated with stereotactic radiosurgery. When you get into the grade 4 and grade 5, I really don't think that it's an option unless the patient's symptomatic, and you've got to treat them because it is symptomatic, but also it's sitting in an eloquent cortex. That's where I think radiosurgery is a benefit. But when you read Pollock's paper about what's ideal for stereotactic radiosurgery, it's an AVM that's lobar on the cortical surface, single feeding arterial vessel, and a single superficial draining vein. Well, that's also music to a surgeon's ears, and it may be music to an endovascular surgeon's ears in terms of our ability to treat. There's been a lot of conversation about the utility of endovascular therapy as an adjunct to either treating the AVM on its own, or as an adjunct to radiosurgery and surgical excision. What you see on top is the AVM. In the middle is what you usually see after embolization, despite the fact that what we want is down on the bottom, where you can reduce the size of the AVM by taking a particular vascular pedicle. That is beneficial. I will say that Dade Lunsford just wrote the chapter for my new book on radiosurgery, and he is in agreement with me that we are not using embolization as an adjunct to radiosurgery, given the fact that it appears that the agents that are used may have an impact on the efficacy of radiosurgery. So I think you have to decide whether you want to treat it with with radiosurgery or not. I think endovascular therapy is a better option when you're either going for a cure or you're going to be using it as an adjunct to surgical excision. And this is an example of a young gentleman that presented to me with, you can see the hemorrhage, and then we can debate the point as to whether you believe in using endovascular therapy for grade 1 and grade 2 AVMs. I have changed my position. I don't operate on lesions now that are obliterated with endovascular therapy. And you can see here that we were able to achieve that here. And again, it's a single vascular pedicle with a single feeder and single draining vein, very amenable to endovascular therapy. And we followed this young man for 10 years and it remains obliterated. All of you are accomplished surgeons, so I'm not going to spend a lot of time on this, but I do feel very strongly that lesions should come to institutions like yours. They shouldn't be going to small community hospitals. I think I can do a little bit of a better job since I've done several hundred AVMs versus somebody that does one maybe a year. So experience both from a surgical perspective, but also endovascular, neurointensive care, radiosurgeon, radiation oncologist, people that focus on the treatment of these lesions are going to be able to give a better visceral response to the patient about what we think is best. And from a surgical perspective, you have to understand all of the anatomical relationships in terms of the neurons, arteries, veins, and sulcal and gyral anatomy and relationship to eloquent cortex. Obviously, positioning is extremely important. The longest time I've been in the operating room alone is 24 hours. I don't do that anymore. If I have a giant AVM, I will stage it. I think that that's a very reasonable way now to go about taking these things out. But certainly while you're in there for 8 hours, you want to be positioned. I don't believe in standing up. I think that you want to be sitting down. You want to have a chair that provides arm support so that you're operating from the wrists, not from the shoulders. This is not a therapy that is minimally invasive. A large bone flap is required. You don't want to be taking AVM out underneath the skull. And you want to minimize any kind of brain retraction. You can see in this cartoon that you put a retractor predominantly on the AVM itself. The surgical principles are involved taking the arterial feeders first, and whether you can do like Dr. Hashimoto does and dissect beautifully within the subarachnoid plane and take the feeders, or you stay in that gliotic margin around the AVM, finding the feeding vessels. Either works quite well, and the venous drainage is taken last. At the end of every case, I do a hypertensive challenge to make sure that there isn't any breakthrough bleeding, and we use intraoperative angiography. This is a cartoon demonstrating the fact that you not only use bipolar cautery, and for that, I recommend strongly the isocools from Codman. They're really non-stick. Your assistant does have to help keep irrigating, but I found them to be most effective. And or you can use these Sunt AVM clips that are also quite effective. So I looked over the past 5 years, we looked at a total of 440 patients that I found that we had seen for AVMs. We had good data on 214, 168 were surgically treated with or without embolization and radiosurgery. 46 were non-surgical, of which 33 were radiosurgery, and only 3 were treated with embolization alone. I would say the literature is a little bit difficult to interpret with the in relation to endovascular therapy. If you read the French literature, they would say that they get 100% obliteration of every AVM they treat. I think the more reasonable range that people will quote is somewhere between a 5 and 40% chance that you can completely obliterate an arteriovenous malformation. And as we showed in that one example, it is for lesions that have 1 or 2 single pedicles with cortical representation. In our population, the most common presentation was intracerebral hemorrhage, with or without interventricular or subarachnoid hemorrhage. And then the second category was incidental. And you can see that 34 of them were found after a workup for headache. And obviously, many of the patients presented with a combination of these symptoms. The distribution between right and left side was equivalent, and the distribution is equivalent in terms of the size of the lobe. Most of them, as you can see, are supratentorial. My population falls into the normal range of about 15. I had 13% of them were infratentorial or in the posterior fossa. That's funny, so let's look at the obliteration rates based on the treatment modality. We had complete obliteration in 182. 8 patients were lost to follow-up. 23 had partial obliteration. And if you look at the treatment modality here and then the obliteration rate, with embolization and radiation therapy, we had complete obliteration 11 and partial in 9. Whereas in surgery, we had surgery alone, we had 22 with 1 loss to follow-up, and then embolization plus surgery, we had 141 with one partial resection that we had a touch up with stereotactic radiosurgery. The outcomes you can see here, the long and short of it, and we considered full recovery with a modified Rankin score of 0 to 1 and a partial recovery associated with modified Rankin scores of 2 to 3. And again, the outcomes were quite good in the lobar lesions, but also what we found remarkable is that even patients that had lesions in their cerebellum, corpus callosum, and brainstem, we were able to get good results. And this is demonstrated here based on the presentation modified Rankin score and their outcome. You see that 175 had a complete recovery, and these results were highly significant. That interventional therapy did result in an improved functional outcome from their presentation. And just an example of what you will bring to the table now is this is a gentleman, obviously it's a small arteriovenous malformation seen in the left frontal area. It had presented with a bleed and a seizure, and we were worried about its relationship to the speech cortex. So we did functional MRI and diffusion tractography and fed all this into the resection of it. You can see the draining vein. This is not a complex lesion. And clearly it's not sitting in any sulcus, so one has to create that gliotic margin around it. And basically it's, I think the tenets here have to be that you stay in that gliotic margin around it, take the draining vein last. And the other thing that I always beat my fellows and residents up on is you don't dig a tunnel, but what you do is you create a plane. And we'll see this more clearly on the next example. And then we have intraoperative angiography with the Zigo system, which we've had for 10 years. We're now going to upgrade that, and we're either going to go to a Philips or to a GE system now because they're more mobile. This is locked on the floor, and it makes it a little bit difficult to use the room for anything else. But it clearly confirms, in association with a hypertensive test and intraoperative angiography, that the AVM has been obliterated. Now, I don't want you to think that I only take out small little distals in the frontal lobe. This is an older video of a young 18-year-old boy who presented with a seizure, and given the fact that he had some small internodal aneurysms, this is a sizable AVM, and he was symptomatic. And at 18, he was going to be presented with a long seizure or a long risk for injury. We recommended surgical intervention. He underwent several embolizations prior, and you can see some of the vessels of the glue. But again, this is another example here, and this is before isocools were developed. But you start creating that plane with the bipolar, and And what you're doing when you're doing this is you're using your sucker aggressively. And once I get into the plane, you'll see that I use the sucker very aggressively and basically look for vessels, cauterize them. And anybody who's taken these out knows that the vessels don't cauterize like any other vessel. So you just have to be patient. This is very different than aneurysm surgery. You know, take a Valium before you get going because it's just a long drawn out procedure. And so here with my sucker, I find the vessel and then I cauterize it, and you know, they either come apart or you try to cut them sharply. And I won't bore you with the long, but you can see here, so what I was talking about is this entire circumferential dissection. There was with the deep draining vein, you see the big, huge venous varix down here, and there's this superficial draining vein, which now is quite blue. That's the deep varix that was down on the bottom. And what we did at this point is come across, I took the superficial draining vein, and then you come across the deep part of it here, and eventually you can get the entire lesion out. After coming across the base of it, boom, it's out. And you can see the retractor isn't really putting any pressure on the surrounding parenchyma. This was before we had good intraoperative angiography, but with postoperative angiography, we confirmed that it was a complete excision. So in analysis of our data, we felt that surgery was superior to the other treatment modalities, and that was statistically significant. And the outcome after surgical treatment was not impacted by eloquence in our analysis, as long as one clearly evaluated the relationship of the AVM to eloquent cortex. And for those lesions that were in eloquent cortex, we would treat with other modalities such as stereotactic radiosurgery. In the surgical subgroup, high modified Rankin score at presentation wasn't predictive of long-term outcome. And AVMs with the Spetzler-Martin graded 1 and 2 are more likely to recover fully after presenting with hemorrhage and undergoing surgery. And as I said earlier, no fatality occurred in our data analysis. So in conclusion, what do we need to be thinking about when we're treating our patients is that difficult lesions are difficult for surgery, radiosurgery, and endovascular therapy. And what this really requires is a teamwork philosophy, whereby, since if you think everything, if all you have is a hammer, everything has to be a nail, that's got to be the wrong approach. There are ways to go about this. And even if you try radiosurgery and it fails, the patient may have been converted into a surgical candidate. And I have several examples of that as well. So I don't think that we should see it as a personal failure, that we as surgeons are not recommending surgical intervention up front, but all of these modalities should be viewed as being complementary and not as competitive. And earlier I talked with you about the molecular biology, and I think that this is going to be one of the most interesting areas. And what do we know? Well, bevacizumab, which we have used in glioblastomas, it's an anti-VEGF agent, and it does seem to reduce the vessel density in mouse models. Angiopoietin-2 antibodies or P13 kinase inhibitors may inhibit AVM formation. And you can read through this list. There are, one of the interesting ones is the trametinib. It's an MEK inhibitor, which is actually in phase 2 clinical trials for extracranial arteriovenous malformations. And an easy medication, monocycline or doxycycline, can be used as a matrix inhibitors and reduce inflammation, and thereby provide some stability and possibly reduce the risk or potential for subsequent hemorrhage. This was the original textbook. I'm hopeful that the new textbook will be coming out next year from Elsevier. Please, you're all welcome to come back to New York. The streets are now open, the restaurants are open, and it's September. We're going to have Broadway back again. So life, I am hopeful, will become much more normal. With that, I will say thank you very much. And I had some cases to present just to sort of, but I understand there aren't a lot of residents, so we won't do that. I'd like to open up the floor just to some questions. Thank you very much for your attention. It's been a pleasure being with you.
Dr. Stieg, it's Steve Monteith, Director of Cerebrovascular. That was a wonderful presentation, and you covered a lot of bases. I had a couple of questions. Do you think the issue with the onyx and radiosurgery is due to targeting? Dr. Steiner at UVA, who I was fortunate enough to train with, was convinced that one of the issues with the onyx was not the absorption of radiation, but was actually that we had difficulty in targeting the lesion. Do you think that's the case, or do you think it's an absorption issue?
The answer is I don't think we know as of yet. The fact of the matter is that there are more reports now that combined embolization with radiosurgery, there's a reduced obliteration rate. I do feel that Ladislau is a good friend of mine, and I spent time in Sweden, so I certainly am indoctrinated into their thought processes. I think with our current imaging technology, we can really target better. So I'm not sure that it's a targeting issue. Back in his day, it probably was, because MRIs weren't as good and the quality of CTA. But one has to assume that there must be some absorptive component to either the onyx or the cyanobuclerate. So like anything else, it's probably a combination of the above.
One other question, in terms of long-term follow-up, there's some data that, particularly looking at children, representation many years after angiographic obliteration on kind of medium-term or several-year follow-up angiography. When do you think it's safe to say that an AVM is truly dead?
What we do, so for anybody that's, any child that we've treated that's under 12, we get a follow-up angiogram at 5 years and then 10 years after that. And so I think that, 15 years out, that by now they're adults, we feel pretty comfortable. And it's not because we know, but that's what I think makes us feel comfortable to tell somebody that they're out of the woods.
Great, thank you.
Dr. Stieg, great talk, and really appreciate your insights on vascular pathology. What are your thoughts on training? When I did my residency, it seemed like more and more stuff is getting radiated, more and more stuff is getting embolized. How do you, see training in the future? Do you think everybody's going to have to do a fellowship in vascular neurosurgery? And what are your thoughts on training? And then also, what do you guys do at Cornell? Because I think, for us here at Swedish, it's it's one of those things every year. We have a great cerebrovascular department, but every year I see that residents are doing less and less open cases.
Right. Yeah, it's a real problem. So our approach towards it is, number one, we do have an Infolded cerebrovascular fellowship, so that from my point of view, if you're going to be a cerebrovascular surgeon, you better know how to do endovascular care. I mean, that horse is out of the barn, I mean, and I know that there are still some stalwarts that try to hold off. I won't name names, but they're all friends of mine. But they're trying to fight that off. That the surgery still is important, and yes, it is. So number one, I think that if you're interested in cerebrovascular, you better do an INR fellowship. Otherwise, you're just not going to be relevant. Number two, I think that you're going to have to do an open fellowship. And where that might be best worked out is in areas where I can tell you in India and in Africa, they're just they can't afford endovascular therapy. It's way too expensive. So if you can get into arenas like that where you can get some additional experience. And what I'm actually finding is now that I've hired faculty that come to me and they want to be cerebrovascular surgeons, and they've done endovascular fellowships. They're okay with the endovascular component, but they're not with the open surgical. So I view junior faculty for a period of time as fellows. And I tell them that right up front, that, listen, you've clipped one aneurysm doesn't mean you're an aneurysm expert,
Mm-hmm.
So, and I don't steal the case, but I work with them, and I try to, and I think that those of us that have experience are going to have to hold on to that talent, and also try to give it to the people that we're bringing on, and not just residents, but faculty as well. Now, the fallout of that is that I'm training the faculty, but then the resident doesn't get it. But, it's got to give somewhere. So it's a real problem. But the reality of it is, with pipeline and webs now,
Right.
the capability that they have for certainly an aneurysm disease is, it used to, for us, when Pierre Gobin started with me, I've had the luxury of working with really good endovascular people. We were, 60-40, 60% clip, 40% embo. Now it's 80% embo, 20% clipping. It's and again, listen, if an endovascular person can cure an AVM, the topic of this conversation, have at it. But I haven't found that to be the majority of cases.
Great. Thank you so much.
Phil, it's great to see you after all these years later in Dallas. Thank you so much for speaking to us. You look great, you sound fantastic, and your material is awesome. And as a silly spine surgeon, I'm not going to venture into this amazing art form of surgery and decision making. My question to you is more of, do you have any advice on how to handle statistical equations to patients and their families? I find it fascinating when I listen to our phenomenal endovascular and vascular group discussions, because so much revolves around statistics. And even as a simple spine surgeon, I find that the relationship of patients and their families to statistics is so arduous and difficult and easily manipulatable. So any thoughts on how to actuate heuristics versus statistics would be so welcome. Thank you.
Well, I'm presuming that being in Seattle, you suffer from the same advantages that we do, in that you have an extremely facile, articulate, computer-savvy patient population. So there, I would, and many of them, and many of our patients in New York, we've got 6 medical schools. So they've already gotten 5 opinions by the time they see me. They've also done their literature search. So they kind of understand what the statistics are. But even beyond that, they have a way of getting into the Sparks databases and looking at what your numbers are. And they have a way of looking at what your lawsuits are about. So my approach towards it is I try to put together my personal data so that I can actually look the patient in the eye. I remember when I was starting in aneurysm surgery, everybody was quoting, Drake's data with basilar tip aneurysms. How realistic is that, right? So you have to kind of look at what you individually do. And I think this is particularly relevant in your area, in spine. So the management of data should be that the surgeon is always looking at their patient population and kind of summarizing where they are. And then they can, and for a competent surgeon, I'm sure most people fit within the range of what standard people are doing. So you can use those numbers, and that's the best you can do for a patient. The worst you can do is lie, which I wouldn't advocate. But you try to give them a reasonable representation of what your experience is, whether it be spine or cranial.
Thank you.
Sounds like we got somebody else on.
Dr. Stieg, it was a pleasure to have you, and we personally, I'm so fascinating. I learn a lot, and I'm hoping I will carry some of the wisdom and teaching from you to my career in future. I'm checking the chat box to see if we have any question from the audience. Okay, Lindsay, I don't see in the chat, I don't see any questions. Do you see anything in your end?
Not,
Linda?
I don't see anything in the chat box.
Yeah, I don't see anything. All right.
Well, thank you very much. It's been a pleasure, and have a great day in Seattle. Is it raining or is the sun shining?
It's sunshine.
Beautiful sun.
One of those rare days. Good.
Thank you so much. Appreciate it.
All right. Take care.